Okay.
Morning, sir.
Good morning. Today we will have a operative surgery discussion on TAPP and TEP repair for groin hernia. So our presenter today will be Dr. Aishwarya, who is a third year junior resident at Arjikar Medical College. And as Dr. Beg is busy with the conference, I'll continue the class. So Aishwarya, you know about the laparoscopic repair for groin hernias. So, before you start the actual steps, we will have some discussion on anatomy and some indications for the technique for laparoscopic repair. So, if I ask you, what is the current uh, recommendation for groin hernia management? Means what technique is recommended to be followed for uh, groin hernia management? In general, maybe EHS guideline or hernia, there are some guidelines which are involved for groin hernia management.
Sir, laparoscopic hernia surgeries are nowadays preferred, especially in cases of bilateral inguinal hernias and recurrent inguinal hernias, sir.
So,
But in patients where the laparoscopic approach cannot be done, for example, maybe the patient has some comorbidities where pneumoperitoneum may not be created. So in those cases, we'll go for open surgery, sir. The surgery that is recommended.
if you go by one liner, the current recommendation for our groin hernia management, I'm not talking of recurrent hernias, it may be it unilateral or bilateral hernias. The recommendation is in favor of either a open mesh repair or laparoscopic mesh repair. Okay.
Yes, sir.
But
Yes, sir.
what the rider is, if you are planning for a laparoscopic repair, you have to have the expertise. That means the center should be having a surgeon who is experienced in doing a laparoscopic, because laparoscopic hernia is a advanced laparoscopic procedure. Okay,
Yes, sir.
so that is in brief the current recommendation. But if you talk of a bilateral hernia or a recurrent hernia which was operated earlier by open, the preferred recommendation is laparoscopic repair.
Yes, sir.
Okay, so these are
Yes,
the
sir.
current status for groin hernia management. So before we go into the actual steps, again, the laparoscopic anatomy is different from open anatomy, as you learned with respect to the deep ring, the suboficial ring, the Hasselbalch triangle. Okay, so if you go by laparoscopic anatomy, as you are entering the peritoneal cavity, you find a different anatomy from the interior.
Yes, sir.
So, what are the different ligaments you are looking at from inside the abdominal cavity?
Sir, mainly we can see three main ligaments. That is the median umbilical ligament, the medial umbilical ligament, and the lateral umbilical ligament, sir.
So, these ligaments are the structures which are inside a fold. This ligament raises a fold of peritoneum. So,
Yes.
this is also now described as fold. If you say it's a median umbilical fold, so this is a fold raised by the median umbilical ligament.
Yes, sir.
What structure is that? The ligament is what?
The median is the urachus, the obliterated urachus.
Yes.
The medial is the left umbilical artery, and the lateral,
Obliterated umbilical artery.
yes, obliterated, and the lateral fold signifies the presence of inferior epigastric vessels, sir.
Okay, fine. So, if you take into the anatomical consideration of these folds, this demarcates some areas in the inguinal area, in the groin area.
Yes.
So, what is that area which is between the median umbilical ligament and the medial umbilical ligament? What is that area called as?
So that is supravesical area,
Yes.
supravesical fossa,
Yes.
and lateral to medial umbilical ligament. There is suprainguinal fossa.
No, medial. That is medial inguinal fossa.
Yes, sir.
What
The
is
lateral to medial umbilical ligament, the suprainguinal fossa, which is again divided into medial and lateral by the lateral umbilical fold.
Yes.
Medial to the lateral
So
is the
between these
medial.
two is a medial inguinal fossa and the lateral inguinal fossa.
Yes, sir.
So these areas are demarcated for each of these hernias.
Yes,
Suprapubic
sir.
hernia happens in suprapubic fossa. The medial inguinal fossa is a place for the direct inguinal hernia, and lateral to the lateral umbilical fold is the lateral inguinal
Indirect one.
to inguinal hernia. So again, there is another important landmark which you would delineate during surgery and take care is the uh, uh, triangle of doom.
Yes, sir.
So, what is the boundary of triangle of doom as you found out during this surgery?
Yes, sir. Triangular dome is a area that is medially bounded by the vas deferens, laterally by the testicular vessels, and inferiorly by the peritoneal reflection of the of or the line joining these two.
So, this is the triangle of doom which is to be taken care of while doing the dissection.
Yes, sir.
And there is an area where mainly the nerves are located. What is that
Yes,
area
sir.
called as?
That is known as triangle of pain, sir.
What nerves are clearly seen in that area?
So this area contains lateral cutaneous nerve of thigh, the femoral nerve, and the femoral branch of the genitofemoral nerve, sir.
Yes. Femoral nerve is not exactly seen because this is deep to the femoral sheath.
Yes, sir.
The nerve to that are clearly seen the genital genitofemoral nerve and the lateral cutaneous nerve of thigh. And femoral nerve is the structure which is there, which lies lateral to the femoral vessels.
Yes, sir.
So, if you take into consideration these areas are to be dissected during the laparoscopic repair. And
Yes, sir.
for ease of dissection, these areas are divided into three zones. So, what are the zones of dissection while doing a TAPP or TEP repair?
Um,
There are three zones of dissection.
okay, sir.
So, you have
Um,
an area which is lateral to the deep inguinal ring, that is the testicular vessels. This is known as
yes, sir.
zone 1.
Okay, sir.
Zone 2 is the medial inguinal fossa, that the area which is medial to the inferior vessels, which is the lateral umbilical fold. So that is the area where you dissect and go to the supravesical fossa or
Okay, sir.
retropubic space of radius. That is zone 2. And the area of the deep ring where the indented hernial sac emerges is the zone 3. So these are the
Okay, sir.
three zones of dissection.
Okay, sir.
So out of TEP and TAPP, what are the clear indications in which situation you can go for a TAPP repair and in which situation go for TEP repair?
Um, um, sir, mm, T TEP is total extraperitoneal repair, and TAPP is transabdominal preperitoneal repair. So, TAPP can be done in cases of um, in general, like
Yes,
unilateral or
in all
bilateral.
groin hernias, small hernias, direct, indirect, reducible, irreducible hernia,
Yes,
TAPP is the technique which you can do. But TP,
yes,
a lot of people prefer to do TP because you are not breaching the peritoneum. You are
yes, but
not doing a new peritoneum and you avoid complications on new peritoneum. But in that case, the hernia has to be reducible. It is difficult to carry out TEP repair in patient who has got a irreducible hernia.
yes, sir. And also, sir, TP is what I've read is not good for severely ill patients.
Severely?
Severely ill patients, sir, or patients
No,
who
no,
had
no, no.
who
Those
already had a
patients who are unfit
state.
for surgery, the patient who has got previous pelvic surgery. Suppose patient has undergone open prostatectomy
Yes, sir.
Okay, so people who have undergone previous pelvic surgery, it is difficult to carry out uh, TEP repair. Okay.
Yes, sir. Yes, sir.
Okay, so this we come to the discussion on uh, actual steps. So these are the basic anatomical considerations and indications for groin hernia surgery.
Yes,
What is the recommendation for asymptomatic hernia? There is an entity called asymptomatic hernia. That means patient has not come to the clinician for the swelling. It is diagnosed in course of other examination. So these are described as asymptomatic hernia. What is the current recommendation for asymptomatic hernias?
sir. So the recommendation, I'm not sure, but I what we do is we suggest the patient to get operated because there is a chance of further complications from the surgery.
No, no, no. If you go by recommendation, the recommendation is not routine repair of hernia in all patients. Okay, then you will have huge number of patients who will be requiring surgery. The recommendation is asymptomatic hernias can be observed because the risk of complication is not high, and again the risk of strangulation and the mortality is not very high in patients who are being observed. So the current recommendation is asymptomatic hernias can be observed.
But sir, I have a question, sir. To after while observing, like what do we expect? Like, do we expect that the hernia will reduce by itself, or
No, no, no.
uh,
Hernia will not be get cured. Try to understand.
yeah, that
Hernia
is
will
what.
not get cured. The
Yes, sir.
point is in asymptomatic hernia, the risk of developing complications is very less, and
Okay.
chance of death following this complication is much remote. So a routine surgery for all asymptomatic hernias are not recommended.
Okay, sir.
So now we will
Okay,
first
sir.
discuss the TAP because both the technique, some parts are almost identical, but
Yes, sir.
uh, we start with the steps of TAPP repair. So, what are the salient steps in TAPP repair?
So after the pre-operative patient, we are taking the patient inside the OT. So the anesthesia will be general anesthesia with endotracheal intubation. Then we'll have to position the patient. The position of the patient will be supine, and the will be supine, and the head end will be downwards, and the ipsilateral side of the hernia will be elevated, like triangular position with elevated ipsilateral side of the
No,
hernia, or
this alteration of position you can do after you create the neoperitoneum. The head end may be
yes,
down, but that making the hernia side up will be done after you achieve neoperitoneum.
yes, sir.
So before you achieve neoperitoneum, you can make the head end down to some extent by 10-15 degree, and otherwise patient is supine.
Yes, sir. So we'll create a pneumoperitoneum. Pneumoperitoneum is created normally by subumbilical incision for a 10 millimeter port. Um, Usually we go with a varus needle insertion into the peritoneal cavity, and then we connect the varus needle with. Before pneumoperitoneum creation, we have to surgical scrubbing, and then draping the patient. Then we'll have to start creating pneumoperitoneum. So after inserting the varus needle, we have to connect it with the CO2 gas pipe, and we have
Connect to the
the
insufflator. You connect to the
yes,
insufflator.
insufflator. Yes, sir. And the intra-abdominal pressure should be around 12.
Looking at the insufflator, how do you make out that your needle is the correct place? Apart from doing the other test, connecting the varus needle to the insufflator machine, now you can make out yes you are in the right place. What machine will show you? The insufflator machine will show you something which will indicate that yes you are in the right place.
So the pressure will be less, low,
Yes.
like
Low
around
means maybe 3 to 5.
3. Yes,
The pressure shown in the instrument machine will be 3 to 5, and if you have set the pressure to 12, the flow will start.
Yes, sir.
If the pressure is shown as 10, 12, 15, then there will be no flow, and that will be an indicator that you are not, the needle is, and either needle is blocked or the needle is not in the peritoneal cavity.
Peritoneal committee. Yes, sir.
Okay, fine.
Yes, sir. So yes, sir. So we'll have to connect it with the insufflator. The pressure should be around 12 mm of Hg, and we can keep the flow rate at 1 liter per minute. Then after the pneumoperitoneum has been achieved, we'll insert a 10 millimeter subumbilical port through which the telescope will go inside. So we'll put the telescope inside and observe the pelvic anatomy, and then we'll create the further ports. That is, two more 5 millimeter ports are inserted. They are usually placed in right.
On entering, how will you ascertain this is a direct hernia or indirect hernia? Looking at this area,
Sir, a direct hernia will bulge through the Hasselbeck's triangle, that is medial to the lateral umbilical fold, and indirect hernia will go through lateral to the lateral umbilical fold, sir.
so looking at this area, we can make out. So if you find the deep ring is closed, if it's
Yes,
a
deep
direct
ring will be,
hernia,
yes,
if it's a direct hernia, you will find the deep ring is closed and the bulge is in the medial inguinal fossa.
yes, sir.
Fine. Next step.
Yes, sir. So now we'll have to create the 5 millimeter ports. They are usually created in the right and left lower quadrant, um, just below the umbilicus and lateral to the rectus abdominis muscle. And while doing this, we have to take care of not injuring the epigastric, inferior epigastric vessels. Then we have then after asserting the type of the hernia, we'll have to start the dissection. So
So
the
what is the next step? The next step will be, once you have created the three pores, you have delineated the anatomy. Now
yes,
the operation will start with the first step for TAPP will be the raising of peritoneal flap.
yes, yes, sir.
So what is the landmark? From where to where you made the peritoneal incision?
From laterally 2 to 3 centimeter medial to the anterior superior iliac spine.
2 centimeters,
Um,
not 3 centimeters, 2 centimeters.
2 centimeter to the anterior superior iliac spine, to about and we have to keep the incision 3 to 4 centimeter above the inguinal ligament, and
From deep side, you do not see the inguinal ligament. You see the iliopubic tract. You find a thickening around the uh, anterior landmark of inguinal ligament, that is called as iliopubic tract.
yes, sir. And medially we have to go till the medial umbilical fold, sir.
Why not cross that area? What is the harm if you take the incision beyond the medial umbilical to the midline?
Sir, there is a chance of injury because the bladder is there, so there is a chance
Yes.
of injury to the bladder,
So,
sir.
so that is the area where the bladder is situated. Although you catheterize the bladder is
Yes,
empty. Okay. So
yes,
before you start, we routinely catheterize the patient in TAPP and TP repair. So the
yes, sir.
recommendation is, do not take the incision beyond the medial umbilical ligament because the bladder is located in that supravesical fossa.
Yes, sir.
Okay. So as I said now, once you made the peritoneal incision, there are three zones of dissection.
Yes,
Okay.
sir.
So if you have a indirect inguinal hernia, you start dissecting first the zone 1, that is the lateral dissection. You start the zone 2 dissection, which is a medial dissection, and then come to the last to the zone 3, that is the hernial sac dissection.
Yes,
So
sir.
that is the sequential steps of dissection. So what is the actual step now? We have made the peritoneal flap incision from just medial to the anterosuperior spine up to the medial umbilical fold, going about 4 centimeter above the iliac tract. Fine.
Yes, sir. Now we have to. Now, next step is downward reflection of the peritoneum and dissection of the preperitoneal space. So we have to continue dissecting the preperitoneal space, which is uh, normally what we do is between the anterior and posterior layer of the fossa transversalis. So we have to go inside. The dissection should be blunt and should be bloodless. Medially, we have to dissect up to the symphysis pubis, and and then below we have to go medially. We should be seeing the Cooper's ligament. It should go up to the obturator foramen, and then along the inguinal ligament, and then laterally we should be able to see the psoas muscle. So this is the boundary. And then if we are dealing with a direct hernia, so while dissecting, we can reduce the direct hernia. We'll be able to see the peritoneal outpouching and pocketing. So that way we can dissect out
As
the
you,
direct
as
hernia.
you, as you, as you catch the peritoneal flap, another whitish line from outside comes. What is that called as? As you in a direct hernia, as you hold the peritoneal flap, another whitish margin is seen, which is coming from outside. What is that called as? That is called as pseudosac.
Yes, sir.
That is called. So you hold the pseudosac and dissect it outward and dissect the peritoneum
Yes, sir.
inward.
Yes, sir.
Now, in
In
the
case of
yes.
Yes, sir, in case of indirect hernia as well, we have to dissect out the pseudosac and from the sac. Um,
So as you find the indirect hernial sac, what is the relation of the hernial sac in indirect hernia with the cord structure? Where do you find the hernial sac in relation to the cord structures?
in indirect hernia lies anterior to the cord structure, sir.
Lateral to the cord structure. So as you pick up the peritoneal flap,
Yes, sir.
you get the hernial sac and the cord structures, that is the testicular vessels, will be lying lateral to this,
Yes, sir.
little posterior and lateral.
Yes, sir.
So now you start dissecting. If it is a complete hernia, what should be your uh, technique of dissecting the indirect hernial sac? If it is a
Sir,
complete hernial, indirect hernial sac, will you fight to dissect and bring out the fundus to the uh, area of dissection? You cannot.
no, sir. If the hernial sac is complete, then hernial sac is transected at the middle,
Yes.
and the distal part is kept open.
Yes. So, if it is a complete hernial sac, you dissect around the peritoneum and try to dissect around the cord structures and
Yes, sir.
funnel around, and you transect the hernial sac,
Yes, sir.
and then you start dissecting proximally. What is the limit of proximal dissection of this peritoneal flap?
Sir, the proximal limit is the point where the vas deferens and the testicular vessels are diverging from each other.
Yes. So as you dissect more proximally, you can see the vas going towards the pelvis.
Yes, sir.
So this dissection is required. This is known as parietalization of the cord. That means as you dissect the peritoneum, out of this the cord become parietalized so that you
Yes,
can place the mesh comfortably. As you lift the
yes,
peritoneum, the mesh will not be lifted up.
yes, sir.
So that is the delineation of the peritoneal space.
Yes, sir.
And what care you should take while you do the zone 1 dissection or the lateral dissection?
So on the zone 1, we have to take care not to injure the nerves
Yes.
and the external iliac vessels also, sir.
Snelling vessel will be in the not in the zone 1, it will be in the triangle of doom. The point
Yes,
is you should keep the fascial covering. The point is in the while you do the zone 1 dissection, you should not disturb the fascial covering, the psoas and the nerves on the lateral side. So that is
okay,
the
sir.
point of dissection.
Yes, sir.
So
Yes,
once
sir.
you clear this, you ensure that there is no bleed, and if there is any bleed, you just suck it off and then change the glove.
Then we then we'll move forward for a fixation of the mesh in the preperitoneal space.
You have to take a proper size mesh. What is the
Yes.
standard mesh you use for?
Normally 12 into 15 centimeter mesh is taken, but
If the
it'll
pressure is high, some people say that you can take a 17 by 12 also. Because as you descend from the level of almost ASIS to beyond the midline, a 17 centimeter mesh transversely can be accommodated. Or a standard is 15 by 12 centimeter
12.
mesh.
Yes, sir.
Okay.
So we have to put the mesh inside the abdomen. So mesh is rolled and it is inserted to the 10 millimeter port. Then we insert the suture material as well. Uh, and we have to place the mesh in such a way that it adequately covers all the hernial potential hernial opening areas.
Like,
Um,
like you have dissected an area where all the groin hernias are uh, taken care of. Now you are saying
yes,
you will put the mesh which will cover all the hernial sides. Like number one, if you come to the medial side,
that is the obturator hernial
so
site.
you have dissected below the Cooper's ligament. Okay.
Yes, sir.
So,
Yes, sir.
and you have gone up to the obturator foramen. So, as you place the mesh medially, it is covering the obturator foramen. So, you take care of obturator hernia. As you
Yes, sir.
come laterally, you have dissected the area of
Hasselback's
femur
triangle.
hernia site. That means
Yes,
you
sir.
have delineated the area between the Cooper's ligament, the lacunar ligament, and the iliopulvic tract. So, that is
Yes,
the
sir.
area of femoral hernia.
Femoral hernia. Yes, sir.
Then you are coming to the medial inguinal fossa, which is
Yes, sir.
right for direct hernia. You
Yes,
have
sir.
delineated the lateral inguinal fossa. You are covering the mesh
Indirect inguinal hernia.
in the inguinal hernia. So this
Yes, sir.
mesh is covering all the defect which are
Yes,
the
it should adequately fit at the myopectinal orifice of Frouchard.
yes. Okay, fine. Then
Yes, sir. Then we have to fix the mesh. The mesh is can be fixed by sutures, and nowadays it is fixed by tackles. So we have to make sure that while
so
fixing
while
the
what precaution you should take while you start fixing the mesh? What will
that
be
we
the
do
at
not
least what will be the minimal fixation sites?
the first fixation should be at the Cooper's ligament, sir.
Compass ligament. And then you fix up and medial. You,
Yes, sir.
you fix it to the up and medial in the anterior wall.
Yes, sir.
You should not apply any tacker or suture
Over the wrinkles.
lateral to the testicular
Over.
fascia.
Yes, sir. Take care of the triangle of doom to not injure the external iliac or
So it
iliac
is said
vessel, sir.
that if the dissection area is properly done, if the mesh can be spread out comfortably, some people do not do even fixation, even for TAPP. But the current recommendation is you should fix to the Cooper's ligament, you should fix to the Cooper's ligament and one or two fixation in the upper medial side,
Yes, sir.
and then closure of.
Then we have to close the peritoneal flap by doing so. We can again use tackers or sutures for closing the peritoneal defect.
For retina flap, it is better that you use a suture material. Huh?
Yes, sir.
If you are not conversant in suturing, you can use tacker, but suture closer the peritoneal flap is recommended.
Yes, sir. Then we'll just take the needle out and take the ports out and make port closure.
What are the complications of TAPP repair?
Sir, there is a chance of injury to the bladder, injury to the other visceral structures, like
So
while
if
making
you
the
go
port.
by complications of TAPP, you have to again classify anesthetic complications, complications
Yes,
related to the neoperitoneum. So neoperitoneum complications may be either because of the hypercarbia cardiac complications, respiratory complications, and complication related to the insertion of varus, injuring the bladder,
Injury to the bladder. Yes.
vascular injury, okay, and
Yes, sir.
specific complications of the hernia surgery, bleeding, bleeding,
Yes, sir. Bleeding,
hematoma,
bleeding hematoma. Yes. Post-operative chronic pain is also a common,
chronic joint pain,
yes,
seroma,
infection.
and recurrence.
Recurrent port site infection, maybe
Yes,
port site hernia as well.
yes. Okay, so we can discuss partly now the TEP repair. We have already discussed the indications. So
Yes.
TEP is an alternate to TAPP repair, and some people claim that TEP repair is much easier. You do not require a neoperitoneum access to the peritoneal cavity. You do not suture the peritoneal flap. Okay, so TEP repair.
Yes, sir.
So how do you get access to the TEP area?
Um, sir,
Again, if you
for
go by
the access,
steps, you go by steps. General anesthesia,
yes, general anesthesia
intubation,
with endotracheal intubation, and then again the position of the patient is supine. Then we have to mm, uh, uh, create a subumbilical port. So, um, no,
how?
after positioning the patient, again we have to surgically scrub the patient and draping, and then create a subumbilical port, and infraumbilical 1.5 centimeter of incision is made, and then we have to dissect the subcutaneous tissue, and then we find the rectus muscle, so we have to
Now, after
retract the
no, no, no. You cannot find rectus muscle after subpenial
no, we have to incise the anterior rectus sheath,
sheath. Yes.
and then we can see the rectus muscle, so we have to
No,
retract
no,
the
try to
rectus muscle.
understand. No, no. It's a little bigger incision. Once you make a incision anterectus sheath, it is better to
Yes.
suture on the cut margin. You take suture on the cut margin of the anterectus sheath so that this suture is kept longer, and you pack this port site to prevent air leak. This suture,
Okay, sir.
you place a gauze piece because this is a little bigger incision than the standard uh, TAP repair. So once you incise anterectus sheath,
Yes.
suture, bicycle suture on either cut margins, and dissect the rectus
Yes, sir.
laterally.
Yes, sir.
So
We have to
you
like dissect the
you find the
rectus
posterior
muscle
rectus
from
sheath.
the linea and then retract laterally.
Yes. So now you find the posterior rectus sheath. Now comes different techniques. If you are conversant with the telescopic dissection, you can pass a 10 millimeter blunt trocar cannula. Take this
Yes.
obturator out, start insufflating. Start insufflating.
The balloon trocar, no, sir.
No, no, no. What I'm saying, not all people use balloon trocar. If you are
Okay.
balloon trocar, you can use a balloon trocar and then inflate the balloon. But most of the people now prefer to use a telescopic dissection. So if you are doing
Okay.
telescopic dissection, you insert a blunt trocar and start insufflating, and then
Okay, sir.
pass a 0-degree telescope because you can see the end where you are dissecting. So pass a 0 telescope and start dissecting in the midline and go gradually up to the midline up to the symphysis pubis. So
Yes, sir.
if you are doing a telescopic dissection, use a 0-degree telescope and start insufflating at the beginning. Alternatively, if
Okay, sir.
using a balloon trocar, you pass a balloon trocar and inflate the balloon. This will create a space between the muscle anteriorly and the posterior sheath
Yes,
posterior.
yes, 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 sir.
So once you have created some space using the telescopic dissection, you dissect on either side. As you go down beyond the arcuate line, so as you go into this plane, there are some landmarks. One landmark is arcuate line. What is this arcuate line? What
Um, uh,
is that arcuate line? What is the demarcating point?
Arcuate line is the line below which all the three layers of the rectus sheath will come in front of the
So,
rectus
as
abdominis
you,
muscle.
as you reach the arcuate line, there is no posterior rectus sheath beyond that.
Yes, sir.
So, beyond the arcuate line, you have the fascia transversalis and the peritoneum.
Peritoneum.
So, the posterior is deficient beyond the arcuate line. So,
Yes.
to go beyond the arcuate line, you can easily go on either side. Clear? Above
Yes, sir.
line, you have the linea alba.
Yes, above lineal. Yes.
So, as you go beyond the arcuate line, you can now transgress to the either side of hernia. So, if you are doing one side hernia, you will remain to that side only. So,
Yes.
you dissect the area in the preperitoneal space on either side. If it's a bilateral hernia on one side, then
Okay, sir.
the
We have to make subsequent ports then.
yes. Again, for TP repair, the options may be different. One technique for port placement will be you are operating with a midline port, putting one port just above the symphysis pubis, another port in between the two.
Yes.
Or it can be two lateral port. Okay, so
Okay.
you dissect the area on either side of the rectus sheath
Yes.
and place 5 millimeter port on either side. So either it can be two lateral port or it can be two midline port.
Two midline ports. Yes, sir.
Once you place the two port, the dissection starts. Again, as
Yes.
I said, there are three zones of dissection.
Yes.
Here you have already done the zone 2 dissection. If in T,
Yes.
yeah,
Yes.
you already have created a space in the midline coming to the symphysis pubis area and the Cooper's ligament area.
Yes.
So as you now go beyond the arcuate line, you will now dissect the zone 1 and the zone 3 dissection.
Yes, sir.
So how do you reach that area now? How to dissect the TEP dissections?
So first we have to identify the Cooper's ligament
Yes.
lateral to the symphysis pubis, and we have to clear if there is any preperitoneal fat there. Then we'll see whether the hernia is indirect or direct type. If it's direct type, then while dissecting, it will get reduced. But if it's in indirect type, then um, um, the indirect hernia will lie lateral to the lateral inferior epigastric vessels, and
So in
it
that
will
case,
lie.
you have to go to the zone 1 dissection.
Yes,
You,
sir.
if for indirect hernial sac, you don't start dissecting at this stage. So once you have done the medial dissection, you have to take that dissection to the lateral side and
Yes,
reflect the peritoneum and remain in the peritoneal space.
yes,
Dissect
sir.
the zone 1. So find the psoas muscle and
Yes, sir.
taking the anterosupplex spine as a landmark, go just medial to the anterosupplex spine.
Yes, sir.
Then you dissect the hernial sac, zone 2 area.
Yes, sir. We have to palatalize the cord structures and dissect the pseudo sac from the true sac, and we have to dissect again till the point of divergence in case of indirect hernia, divergence of the vas deferens and the testicular vessels, and then we have to place the mesh in the preperitoneal space, fix it, and then
So
close the
again,
pen.
again, the TP is a plane where people are more in favor of not fixing. Because in TAPP repair, you have lifted a peritoneal flap and you place the mesh, and mesh fixation is more often required in TAPP repair. If you are in the TEP plane, in TP plane, if you place the mesh gets sandwiched between your dissection planes. So in
Okay.
TP repair, you can just place only one fixation in the Cooper's ligament. Or people who are
Okay.
more of TEP repair person, they claim that no fixation is required for TEP repair. You just spread
Okay,
out the mesh and do gradual desufflation. So if you do
okay,
gradual desufflation, you can place the mesh without fixation.
okay, sir.
So this is a TP dissection.
Yes, sir.
And the advantage of TP is you need not suture the
Into
peritoneal
the
flap.
patient.
You
Yes,
have to suture. You have made a little longer incision than the rectus sheath, so you have to suture the sheath in the subumbilical area.
yes, sir.
And if you already taken the stitch in the anterector sheath, you just tie those stitches.
The stay sutures. Yes,
Okay. What is the
yes, sir.
post-op care? Post-op care following this hernia repair.
Post-operatively, um, we have to give the patient fluid for like 1 day,
You
and
can you can start the patient on oral fluid from the same evening. If you're operating in the morning, you can start the patient on oral fluid in the same evening.
okay,
Okay.
sir.
So patient
Yes,
has
sir.
been given general anesthesia. You
Yes, sir.
keep the patient on IV fluid, and
Give the
once the
patient
patient
antibiotic
is not
analgesic.
having vomiting, you start the patient on oral fluid in the same evening, and by next morning patient be off IV fluid. And if your strategy is to give, we usually give a prophylactic antibiotic. So you give the antibiotic, some amount of analgesic is required, and
Yes,
patient can be discharged home by 1 or 2 days time.
yes, sir. And we'll have to monitor whether there is any kind of hematoma formation, infection,
Yes,
seroma formation or not.
yes.
So in
Post-op
TP repair,
patient come with a seroma. In the post-op period, after 10 12 days, you come see the patient has got a swelling in the hernial site. So a seroma is formed. What is the uh, strategy for seroma management in post-op period?
so initially, if the swelling is really big, then we have to
What
we can
happens to the
aspirate.
what happens to most of the seromas? What happens to most of the seromas?
Usually, majority of the seromas they get
So
resolved by themselves.
the
So
strategy for management of seroma is wait and watch. Most of the
yes, sir.
seromas resolve spontaneously. It is not necessary to aspirate. Okay,
Yes, sir.
so
Yes, sir.
the treatment for seroma is wait and watch.
Yes, sir. But if it's big enough and causing some problem to the patient, we can aspirate. We can give the
Yes,
patient chimoral and
with
all.
under aseptic precaution. Okay,
Yes, sir.
under aseptic precaution.
Yes, sir.
Okay.
So during TP surgery, if there is breach of peritoneum, so what do we do?
Yes. Yes. So while doing TP repair, there is a breach in peritoneum. What is the problem? What is the difficulty if there is a breach in the peritoneum?
So we will have to the air will enter into the peritoneum, so it will convert into a TAPP.
No, not always. You need to convert to TPP because if there is an opening, there is neoperitoneum that causes reduction of the space as you are dissecting. So in that case, strategy will be you can pass a varus needle in the peritoneal cavity so that this varus needle will cause escape of gas from the peritoneal cavity, and this can open up your preperitoneal space. Or
So
if
we'll have to
yes, you pass a
we'll have,
varus needle.
so the varus needle will be kept throughout the surgery because the defect is still there. So we
Yes,
are not repairing it.
yes, till the end of surgery. So at the end of surgery, you deflate the abdominal cavity. Once
Okay.
you stop the insufflation, keep the varus needle till you find the abdomen is deflated. If you
Okay.
have lot of difficulty that even the varus needle you cannot get the space, then only you consider conversion to TAPP.
So, is there any scope of repairing the peritoneum if the breach is really
Yes,
like big?
yes, the expert people who are doing on regular basis TAPP, you can close the peritoneum. Yes, you can suture. The rent that has happened, you can suture the rent. So this will be taken care of.
Okay, sir.
Hmm. So what is E-tape repair? What is
Yes, sir.
what is E-tape repair for groin hernia? E-tape. What does the term
So,
E-tape stand for?
E-tape is a modification of tape surgery that
What
is
is E stands for?
enhanced
What is
enhanced view total extraperitoneal approach, sir.
so enhanced view total extraperitoneal repair. So what is the principle? Why do people come with the idea that E-tape is a better way of addressing particularly bilateral hernias?
Sir, for tape surgery, this view of the surgical field is usually many of the times poor, and there is a chance of accidental peritoneum disruption. So, this E tape has a better view. In this E tape, we put the 10 millimeter trocar a bit more cephalad and a bit lateral to the normal position of the
If you say lateral, what should be the landmark? How far lateral you can go, and beyond that you should not go. It should be medial to the semilunaris line.
okay, sir.
Okay, it should not be
Yes, sir.
lateral to the linea semilunaris. Then you will be out of rectus sheath.
Yes, sir.
This lateral, in E-tape procedure, the first port is made more kiphalat and
Yes,
lateral,
sir.
but medial to the linea semilunaris.
Medial to, yes, sir.
So you start insufflating, you get a bigger space. If
Yes, sir.
required, you can do crossover. You can do crossover on the lineal path and come to the opposite side. Okay. So
Okay.
for MS, E-tape will not be asked, definitely.
So
TAPP and
for
T good enough.
yes, sir. Yes, sir,
Okay.
for TAP, sir, for TAPP, we put the ports on either of the like lower, right and left lower abdomen. But in one of the videos, I was seeing that the 5 millimeter ports were put in same side. So like
Now, same side means if you are doing unilateral hernia, you can put on the same side. But
okay,
if it is a bilateral hernia, it will be easier to put on either side. Okay. Suppose you are doing a right groin hernia, you can
yes,
put
sir.
working port on the left side.
Yes, sir.
But standard port is the lateral ports.
Okay, sir. And sir, what is the ideal position of the assistant? So who is showing the camera? Is it opposite to
Assistant
the
should be
operator?
opposite to surgeon. Yes. Surgeon will be, you see, there are some surgeon who can stand on the head and side and
Yes,
opposite
sir.
both sides. Usually it is convenient for the surgeon to stand on the side opposite to the side of hernia. So if you are doing a right hernia, surgeon stands on the left side and assistant stands on the opposite side. There is a standard position.
That is assistant on the ipsilateral side of the hernia.
Opposite to surgeon.
Yes, yes. Okay. And assistant can stand on the head and side also. It'll depend on the convenience of the surgeon.
Yes, because you see, these are all very close port. These are all
Yes, sir.
very close port.
Mm.
The standard recommendation is surgeon stands on the side opposite to the hernia. If you are doing bilateral, you can change sides.
Okay, sir.
Okay. Thank you. Thank you.
Thank you, sir.
Thank you.
Thank you, sir.
Okay.